So let's start with this case. So I think Didier,
Okay.
yeah, Didier, you briefly, no, you carefully reviewed the anatomy.
Yeah.
So we're here in the room with Norway team,
Sorry.
with Ahmed and Anders,
Yeah.
and all the rest of the team that is surrounding us, and it's a great pleasure.
Yeah, we see on the
It's our
screen.
pleasure.
We see
Yeah,
you.
yeah. The
You're looking
patient
good,
is
huh?
the patient is quite a conventional TAVI patient, 88 years old, a previous history of renal surgery for carcinoma that is now passed and solved. Permanent atrial fibrillation, moderate chronic kidney disease as a resultant of his chronic history. And of course, congestive heart failure related to the aortic stenosis, normal left ventricular function, tight monotruncular stenosis on mid-LAD on coronary angiogram that was treated by PCI some days ago. And you reviewed the anatomy. So our plan is to go through the left axis because you saw that there was a quite important tortuosity on the right.
Yeah, we could see it.
Yeah.
So tortuous and a little bit calcified also.
Yeah, and on the left, so what is interesting, because I'm here with Ahmed and Anders who are not familiar with echo-guided puncture. I think the other teams with you are. So I was just showing them that you see here in long axis, so the left femoral axis, you saw a bifurcation with the superficialis and the profunda. And now I'm shifting to a more cranial position, and you perfectly see those kind of posterior plaque lesions that you try sometimes to avoid because you can be stuck with your posterior proglide in that, and it can lead to a connection issue. And then you can, if you try, if possible, to go a little bit above. And I think here it would be a nice spot. So after that, the technique is always the same. You hold your left hand in order to have your long axis view. You start with your lidocaine injection. So as mentioned, it's possible to tailor the anesthesia as you see, and really to inject the lidocaine at the contact of the artery. So for the comfort of the patient, sometimes it's better. And you see less than 1 syringe, it's okay. After that, coming to my slice here. Okay, long axis again. So we're going to first locate the needle. So my left hand doesn't move.
Do you have a comment?
Yes, sorry.
Yeah, we can see the needle nicely.
Yeah, you see the needle. So
yeah.
Technically speaking, from my colleagues here who are not familiar, so my left hand doesn't move. I keep my slice, and my right hand try to be in the plane of the ultrasound. Okay, yeah. So when I've done that, you see I lost it. So here you see my needle. When I've done that, I'm smoothly pushing on the roof of the artery, but at that step I'm not sure that I'm central. Okay, so then I go to a short axis view, and I try to locate my needle.
Yeah, we can see that you are slightly too medial.
Okay, you see that? I'll try to locate and to illustrate that better.
Yeah.
So it needs some
you're
time.
coming more central. Okay.
Okay.
Here you are, yeah.
And you see the needle here, okay? And you perfectly see the needle on the roof of the artery here. And then you just have to advance your needle.
And we could see that there wasn't any plaque. It was exactly where the junction between both locations with plaques. It was free of calcium.
Yeah, after that, at the time of doing that, we have asked to our colleague anesthesiologist to inject the heparin. So it was 3,000 units for this patient, and we'll check the ACT. Just, of course, insert the 6 French sheath just to make the path. Dissect the subcutaneous tissue as you routinely do, I think. Patient is not obese, it's quite thin, you see, so we were close to the artery, so it's fine. Now going to insert the first ProGlide. Okay. So you know that you have several techniques, either crossed or parallel. So here it will be a crossed technique. So insertion in the artery, turn to 10 o'clock, open it, stuck against the wall, connection of the needles. Everything of this is quite standard for everybody, I think. Cutting of the strings, withdrawal of both strings, the long blue one, the short white one, and we attach them on the drape and go for the second. While preparing also the patient, Didier, because of we mentioned that briefly,
Yeah.
because of complete right bundle branch block plus left anterior ME block, I've already positioned a temporary pacemaker lead that the patient will keep in the ICU, even though
from the right vein, femoral vein.
From the right femoral vein, even though we don't have a high degree AV block during the procedure. I think I will leave that until tomorrow for safety issues, because we know that those kind of patients are at risk of delayed high degree AV block.
It makes sense. Just for the audience, Nicolas, would you slightly pull on one of the ProGlide just to understand that he removed the slack, in fact, from the device?
Yeah.
And he is in contact with the anterior wall of the vessel. So you have to keep both strings parallel and pull until you see that you are holding the artery. And this maximizes the chances of success of the ProGlide.
Okay, after that, I'm using the ProGlide as a long sheath to introduce, of course, carefully the
8 French.
The Lunderquist wire.
Even the vein is extremely tortuous in this patient. It's crazy.
C'est bon, Sabine? Non, Coro, il s'appelle.
C'est le tout dernier, tout en bas.
Ouais, tiens, attends, fais voir. Sorry. Hop là, ok.
Je l'ai rempli déjà. Faut le faire, faut que tu descendes.
Okay, so the Lunderquist is in. It's fine. And then we'll go with the 16 French. Yeah. So now while doing that, maybe we can take several seconds to discuss the sizing issues and the aortic root anatomy. Didier, I think you saw that it's quite a heavily calcified valve.
Yeah, we saw that, and we had a concern maybe it could be a kind of pseudo bicuspid or functional bicuspid, because there is a close relationship between the left and the right coronary sinus, and so maybe it's a kind of a pseudo bicuspid. So we did a measurement at the level of the intercommissural distance, and it provided us with 25. So 25 is in the range of the annulus, that was 24. So it's the same sizing. It provides the same device, 29. It's more about pre-dilatation or not, and or post-dilatation. So what did you decide?
So what we have chosen a 29 Evolut Pro device based on the measurements you've mentioned. And we'll go for direct implantation, but anticipate maybe an amount.
I need to post-dilate.
Amount of PV leak that will be a little bit more important than usual, especially linked to the calcification you've seen coming down from the right coronary cusp to the LVOT. You've seen that 2 or 3 millimeters below the annulus. You see a huge calcification that is coming down. Je prends pour la CT, s'il vous plaît. And then we'll anticipate maybe to post-dilate. So as the measurement of the annulus was between 23, 24, I've already asked to have in the room a 23 millimeter balloon for post-dilatation, and we'll be ready to use it if necessary. Okay, just a little blood sample for a CT measurement, then hemodynamic recording, flush everything. Ok. Tu me donneras des éponges aussi, Sabine, après? Some extra bits, but now it's stable, yeah. So we see the aortic diastolic pressure that is 41, and diastolic LV and pressure
20.
that is 20. We keep this in mind. And of course, we will record that at the end again. So now we're going to insert the Safari wire. That is a conventional routine small Safari. Okay, let's say if it's properly seated, you see the AL catheter was upside down. So what we usually do is just try a few seconds to properly position it, and if it doesn't work, we exchange with a pigtail, of course. Okay, good.
Pigtail from the radial artery.
And yeah, Hamed is reminding me that I forgot to insert the pigtail through the radial artery, so we're going to do that.
For the angiography. Yeah.
for the angio.
Yeah. So you're going to do it without contrast, based on the calcium?
La pigtail, s'il te plaît, je te prends. Yeah, because we have not done yet TAVI implantation without pigtail.
No, not yet.
So, and just a small technical point that we've discussed together, because the team that is here with me is currently using a dual femoral approach for the TAVI. So, coming from a radial, as we want to monitor the pressure through the radial axis and also to insert the pigtail, what we use is a pigtail that is 1 French smaller than the sheath we have in the radial. And second, what we do is that we use a long sheath that is ending in the brachial artery in order to be sure not to have a dumped arterial pressure once the pigtail is inside, although it's 1 French lower than the sheath size. Ok, let's connect. On va se brancher à l'injecteur, s'il vous plaît. Ok, vous pouvez purger. Et it was LAO.
Do you have questions?
LAO 14.
Do you have questions? No, it's okay.
LAO 8. 8 or 10.
8, yeah. LAO 10, Didier?
Yeah, LAO 10. But you are raising a lot of excitement here. It's nice. I don't understand everything, but
LAO, ok. On va enregistrer ça?
Yeah, it has to be at least 30 centimeters just to sit in the brachial. This way you can monitor the blood pressure.
It's not the good sinus, you see?
If it ends it, here it's going to be,
right.
you're going to get spasm. So no blood pressure.
Okay, this one is
so these are small details, but
it changes. Sabine? No, it's still the right.
No, it seems to be a good projection, but the pigtail is on the right sinus.
Is on the right sinus, yeah. Okay, we have an ACT at 195.
No,
okay, it's good.
This one.
Okay, this is...
Okay, so we're fine. So I'm going just to change my glove, insert the catheter, and then if you want, I can leave you implant the valve. I will be with you, of course.
Yeah. Okay. It's okay.
And when we do that, we change the gloves. It's not really for sterile purposes. It's just to make a pause before you go for the device to make sure that everybody is aligned and everybody is engaged in the deployment of the device. So we make it a sort of break.
The valve before you.
No, Didier, we have an interesting question we have each time, but that is interesting
we didn't check.
to discuss. Yeah, we don't check the valve under X-ray and the fluoroscopy, so it's not a Medtronic recommendation, of course.
Okay.
Medtronic, essaie de le passer dessus, s'il te plaît.
Yeah.
Medtronic
so
recommendation
Dora is with us, so
yeah.
we
So
have
you,
to say
of course,
that you should.
Yeah, you should. You have to follow Medtronic recommendation, but maybe you can help me. But to be honest, as the nurses' teams are well trained, I think, if they don't identify loading issues, we don't check under X-ray. And for the moment, doing that now for 2 years, I think, we didn't experience any issues. So I will ask you maybe to hold the stiff wire, if you don't mind.
Yeah,
Okay, just watch the screen. And because I felt a little bit of resistance to enter the vessels. Okay. And okay, we have to navigate through that. It's good. Okay, and now the stage is yours. So are you familiar with GE equipment?
Not yet.
No. So just some things for you to be comfortable.
Yeah.
So
This one
X-ray, it's the left pedal.
Yeah.
Okay. Angio recording is on the right.
Yeah.
If you need a test, you ask to the nurse.
Yeah.
You can go here, and I will be with you, and you will release the valve together. I will adapt the projection, the mag and everything. Okay. Okay, so you can
just pull the wire.
Pull the wire, pull on the wire a little bit. Okay, good. Florian, vous pouvez pousser l'écran vers moi, s'il vous plaît. And make a slight pause here, just for us to align. Coming back to the projection we had.
Here
Okay,
you have a quite good coaxiality.
Yeah.
Usually it's not the case. Here it's perfectly aligned.
Okay. So you can go, I think, maybe 1 or 2 millimeters below. Yes,
like
stop here. Maybe a little bit higher. And we'll do, our first angio, so with the right pedal, in order to record our initial position.
Yeah. Contrast.
And just for you here in the room, that's what I was explaining before. It's very important that your left hand holds the sheath and pushing towards the head of the patient to have something stable.
Yeah.
And the right hand has to be 1 centimeter close to the left hand.
Yeah.
This way you're going
perfectly
to
doing,
you're going to do very minimal movements. So it's really important to get.
You can open it now.
Yeah. Sorry. Didier was making a comment about the position of the hands of the first.
Of my hands.
Yeah. I was using your visual because you are doing it exactly in the right way. So I was using it to demonstrate the position of the hands.
Okay, so it's good. Perfect. Good.
So what's your target? 3 to 5, slightly higher, or?
No, I think 3 to 5 will be good.
Yeah, because if there is a concern of potential heavy block for this patient, it shouldn't be too deep.
It's very nice.
Yeah. But I think as it is right now, it's good.
Yeah, it's good. It's very nice.
Yeah, you can continue, I think.
Are you happy with the position here in the room?
Yeah. So maybe you can make a pause. And we'll record because you see the angio quality is not good because of a patient. So you can make a
cine.
A cine.
Contrast.
Yeah, with a contrast.
Yes.
Okay, it's perfect. Okay.
Yeah.
Good depth.
Keep going.
You can keep on.
Continue to open.
Can go. And then in a few seconds, you see they will be occlusive, so they will speed up a little bit.
So that's something that we see from time to time when it is extremely calcified. You see that the inflow portion doesn't expand.
Yeah.
So you have two possibilities. Either you leave it in place and then you go for a post dilatation, or you can resheath, go a little bit lower, expand a little bit, and then go back at target. This way you're going to have more expansion of the inflow.
So just for you, because you don't have a mic, what Didier is explaining.
Yeah, it's not opening.
You can make a cine without contrast, just to illustrate that. So hemodynamic is good, so we have time to discuss. Depth of implantation is good. But as we could anticipate because of the amount of calcification, expansion of a frame is not total. Okay? So at this step, as the hemodynamic is good, we have two options. We can recapture, go a little bit lower and reopen, and sometimes it works. Or we can leave a prosthesis like that and post-dilate.
Yeah.
Okay? So I think we can recapture.
Recapture it,
yeah.
I think it's better.
We can recapture a little bit. Okay? Just for you to lose contact.
And sometimes it's quite interesting because you do a kind of pre-dilatation with the device, in fact.
Exactly,
yeah.
exactly.
And it's if you go lower, it expands. So it's quite interesting. We're going to see.
Okay, so I think you're fine.
Fine.
Now you can be a little bit lower.
Yeah, go a little bit lower. Now, yes.
I think it's good. And now you can come back to opening. Patient is perfectly stable. You see.
Yeah.
No
really
third degree heavy block. So you have time. Tu peux préparer le ballon de 23. Ouais.
Yeah, you see it's slightly
better.
Okay.
Yeah, it's better. It's quite interesting to see because from time to time we see that you have more expansion, but you will need to pause dilate.
Yeah. So you can stop, and we'll record an angio with contrast.
Yes. Contrast.
Because the depth, do you agree, Nico? Maybe you can comment on that the depth is going to guide the post dilatation also, because if you need to post dilate, you don't want to be extremely high.
Exactly. So I think the depth is good.
It's good for post
because it's a good trade-off between the risk of heavy block. The height, as Didier was commenting, that shouldn't be too high if we want to post dilate.
Yeah.
So it's good, but we're still underexpanded. Okay.
Yeah.
So we're going to release the valve here and to post dilate. Yeah. Okay. So we're going to leave the pigtail here also, because it will be a landmark while waiting for the post dilatation. Okay. So you can
so keep the
go back to the X-rays. Okay, I'm just slightly pulling on the wire, you see, in order to center the nose cone. Okay, and then you can release the valve. Yeah. And Ahmed is slightly maintaining coaxiality, is pushing, yeah. Okay, you can push a little bit more, Ahmed. Okay, push a little bit more. Okay, good. Yeah, and okay, everything is detached, so you're carefully pulling, and I'm managing the nose cone, okay?
And
ouais, nominal, ouais. Withdrawing everything. Okay, and I let you press the groin, and I just withdraw the device, okay?
So when you are preparing everything for the post-dilatation, just a small trick that I can share with you. When you post-dilate, we often see is a kind of foreshortening of the stent frame. It goes higher. So you need to counteract, and you need to balance that movement. While the balloon expands, you need to push downwards. Continue push aggressively, and this until you see during deflation that the balloon goes within the left ventricle. This is going to prevent or at least minimize the upward movement of the device. And it's the way to be more stable and to keep the depth that you've decided.
Yeah, it's fine.
So they're going to illustrate that.
Here with you, just hold the sheath, and I'm going to withdraw the dilator. That's fine.
Il y en a un qui a rendu l'âme, c'est moi.
Okay. Okay, so while waiting for the balloon, so as we mentioned, it will be a 23 millimeter balloon. So while waiting for the balloon, we see that we, at the moment, still don't have a third degree heavy block.
No.
Pressure is good. So we are in stable conditions.
It's a little bit low diastolic pressure.
Yeah, excellent.
The valve is somewhat more expanded now.
Yeah, a little bit more expanded. So you can make maybe let's try to align it a little bit better. Okay. Remove parallax and okay.
Yeah.
And you see that it's worth post dilating, right? But you see that we are quite high, huh?
Yeah.
So it's one of the challenging situations Didier was mentioning, where during post-dilatation with a foreshortening of the valve, we may end up at the zero position with the inflow portion of the frame. So we will have to strongly push on the balloon. I will do that to show you if you want. We'll have to strongly push on the balloon in order to try to compensate that.
When you dilate it, push.
Yeah. And what we can
do.
do also is just at the moment, remove a pigtail. The position is really unusual, but we're going to test it. Florian, est-ce qu'on peut tester le pace juste pour voir s'il fonctionne bien, parce qu'il a vas-y, c'est bon pour le ballon. Non, un petit coup à 180 pour voir si ça fonctionne bien. Ok, stop, c'est bon. Ok, so pacing is still good. Yeah, it's working. C'est bon, tu as le guide, Sabine? Et Florian, si vous pouvez venir pour la post-dilatation. Okay, so you're familiar with this? It's a inflation device, and it's just locked and locked. And you go full way.
Yeah.
We'll make maybe 2 seconds full inflation and then deflate.
And then loss it. Yeah.
Okay, and I will push. I will tell you when I would like you to inflate. Okay, we'll wait for the pressure to really drop down and to be really stable. So 200, on va mettre. And as you see with my hands, I'm holding the wire in order to have a good support in the left ventricle, and I will advance everything while pushing. Yeah. Okay? Stimulation. Okay, so we have a good capture. Let's wait. Okay, and you can inflate. Okay, I'm pushing. Deflate. Okay, stop pacing.
Yeah, very nice. So you really need to see that the balloon goes downwards.
Stop pacing.
This way you can minimize the...
Okay, and now you can pace. Mettez-vous en VVI à 70, because now we have 3rd degree heavy block, maybe. A little bit transient. But... okay.
So there will be foreshortening because there is always, but just to minimize it.
Yeah. Okay. Thank you. Let's record the hemodynamic.
Pigtail.
So she's going to put the pigtail. Sabine, s'il te plaît, la pigtail. Sur la table, derrière toi. Florian, là maintenant, arrêtez la stimulation pour voir s'il a retrouvé son rythme. No, you see?
It's total.
Yeah, total. So.
Florian, il peut remettre.
Mettez à 80 même. Okay. So it was necessary to anticipate that, yeah. But it's not a big surprise, with this kind of
with the calcium spike in the left.
With this kind of combination of conduction disturbances, calcium severity and repartition, it's highly probable. Huh? Okay, so let's record that. The amount, the level of aortic diastolic pressure is almost the same than initially, I think, at the beginning.
The same, yeah. 50.
And diastolic is almost the same also.
Yeah.
So the only thing we changed is the gradient, fortunately. But it looks good. Ok. Le starter. Tu peux mettre 20 cc pour l'angio. Okay, withdraw that. Now, re-advance the pigtail. It's a little bit too low. Here is good.
It was really interesting, that calcified anatomy.
On y va?
And do you think, Nico, that it would have been different with a pre-dilatation?
It's a difficult question. I don't know.
Sure.
Nice.
Yeah, not
Very
sure.
nice.
Not
Okay,
sure
so it's really better than
That's
initially.
very nice.
Yeah.
You got more than 50% expansion of the overall stent frame with the post-dilatation. So
we see that we are really now at the level zero.
Yeah.
But regarding the ceiling, it's not an issue. And regarding the AV conduction,
See the
potential
left coronary arteries or
Yeah.
left main?
Yeah, the left main is good.
the diastolic is improving. It's close to 60 now, so it's nice.
Okay, so let's close. Le Terumo, s'il vous plaît.
It's 20 cc's. 20 cc's. There is a mild regurgitation. If you combine that with the diastolic that is 60, it's yeah.
Mets-toi en champ zéro.
It's not even moderate, so it's okay, it's fine. It's unusual. It's in the coronary sinus, I guess, but it's working. So.
Yeah. The position of a pacing lead is totally unusual, but the issue with this small 4 French one is that it's not always easy to guide.
To stabilize. Huh?
Yeah, and then once you found a position that is efficient, effective, you're happy with that.
So if you decide to go from the right axis, we started with the left radial. Because left radial, you have a shorter distance to get access to the common femoral artery, but it wasn't convenient for our backs. So we decided to come back to the right radial. So you need to provide to bring long catheters enough, a long pigtail, at least 125, 130, long wires, long balloons, if you need to occlude the vessel. So you need to be prepared for that.
Okay, and so what we do when we use the ProGlide technique, because Didier, you've shown a Manta case before, I think as you do in your center and as many of us do or doing, we leave a jailed wire, close on the wire, just to have the opportunity in case of incomplete result to put on that wire an additional device. Okay? May I ask you, just to withdraw the sheath and just keep the wire in place, please? Thank you. So this is the first knot. Okay. Let's tie the second one. So we're still using 2 ProGlides. We have not yet shifted to 1 ProGlide. But I know
because as you mentioned, sometimes it's difficult to put the other one. Yeah. That's why we use one, because you always can manage to put one ProGlide.
Okay.
It's okay.
So
I will accept it.
Yeah, you see, it's in our routine practice. We have 2 options here. Either to put a 6 French angioseal, but it's just to gain time as compared to compression. Yeah. But here, if you remember the echo we had initially, we had some posterior plaques, some posterior lesions, some quite, let's say, diseased vessel. So what I'm going to do is just to close,
and when you push,
make the angio with a wire in place.
Okay.
Just assess whether we have a significant regurgitation on the pathway of a wire, or whether we have a stenosis at the place of a suture, and then decide on those elements whether I put an additional device or whether we compress. Okay, because it's this tiny residual bleeding is totally accessible to compression. Okay. So we have to assess that. On va se reconnecter à l'injecteur, s'il vous plaît. Ok, en soustraction. C'est bon?
Yeah, it's really nice.
So you see, we have the answers to our 2 questions. We don't have a significant bleeding on the pathway of the wire. and we don't have a stenosis. So I think we can stop there and just compress. We could also put an angiosyl 6 range, but to be honest, it's just to gain time as to compare to compression. And you see here, you just have a residual tiny bleeding. So it's a thing we can withdraw. Okay. So thank you. See you in a few seconds. And of course, we leave the pacemaker in place. Yeah.
Okay, good job. Congratulations.
Thank you
very much.